Good evening, everyone, and welcome to the next installment of the ASMS webinar series, Advances in Craniofacial Surgical Planning, Incorporating Surgical Planning into Your Practice. Our presenters this evening are Dr. Anand Kumar of Johns Hopkins University School of Medicine and Dr. Gaby Doumit of the University of Montreal Cleveland Clinic. On your screen, you should see what is shown as a Q&A pod. This is the pod through which you can type questions of the presenters. And as we go through this evening's presentations, they will be answering those questions, very likely towards the end. Dr. Kumar will speak first, and Dr. Doumit will speak second. So please feel free to type your questions in anytime. And at this point, I will pass the presentation on to Dr. Kumar.
Great, thanks, Stan. I really appreciate it. For all those that are checking in via the webinar, thanks for logging in with us. And I'll be starting with advances in craniofacial surgical planning, incorporating virtual surgical planning into your practice. As we get going, as always, the disclosures: I have no commercial financial interests. We have been fortunate to be funded by the Military and Veterans Health Institute at Hopkins and have a couple of patents filed. Everything I've shown you tonight will be and has been reviewed by the IRB at Johns Hopkins as it pertains to research. So what are we going to do tonight? Well, I wanted to sort of go over the indications for virtual surgical planning and splint fabrication and its use. I kind of wanted to look at this in a context of history. I very much am very interested in where we've been, and it sort of gives us an insight into where we're going, I think. So we will talk about a little bit about the history of dentofacial splint development, technology considerations as it relates to anatomy, and then most importantly, going over particular cases and looking at the evolving role of surgical planning, looking at the class 2 patient with malocclusion with or without the occlusal cant abnormality, the class 3 patient, orbital malposition, and we'll use a case of orbital box compression osteotomy as an example, and also look at exorbitism, taylorism, and the facial bipartition procedure, and see how VSP can be used to facilitate treatment planning. When going over this, I think it's always important to keep a very critical eye as to what you think is truly adding value to your practice and what is merely sort of gimmickry or just sort of computer planning. And I think there's no question, as you'll come to the end of this presentation, that the fabrication of splints, particularly for orthognathic class 2 and class 3 malocclusion cases, is immensely helpful. I think there's certainly room to debate regarding the efficacy and cost utilization for, quote, craniofacial cases. But I think time will help us decide that question. So let's look at the real issue. The problem, as it always has been and always will be, is really two problems, which is dentoalveolar segment control, right? Any segmental osteotomy that has tooth-bearing segments and the control of those tooth-bearing segments. And lastly, the actual facial skeleton malposition and the osteotomy segment control. I think the key words here is control of segments. I have 3 examples here of sort of more challenging problems where you're going to segment the craniofacial skeleton and then try to achieve control and thereby predictable post-surgical results. So what's the real history? The real history is that this starts with people always trying to deal with issues of the broken bone, either through iatrogenic issues, through facial trauma, or through specific facial osteotomies. And it really starts with John Rhea Barton, who was quite an interesting American surgeon at the Pennsylvania Hospital. And he was the first person that really developed the figure of 8 facial dressing for facial fractures. This guy was rather interesting in that he never moved during surgery and was ambidextrous. And what his most famous move was for the femoral osteotomy in 7 minutes. Now, this is sort of the rudimentary beginnings of control of the skeleton. And what we really see is the next development in facial skeletal surgery is during the American Civil War. And you can see here that Thomas Bryan Gunning is a Union dentist and really part of the Union Army. And he is sort of he's credited for the development of interdental splint during the Civil War. And sort of his Confederate counterpart, Dr. James Baxter Bean, also was very much instrumental in the development of interdental splints and vulcanite, which is a rare copper telluride mineral. But I guess history judges the winner, not the loser, and we all sort of talk about the Gunning splint, not necessarily the Bean splint. So let's look at really with dentofacial control really came the need then to be able to move the skeleton. And Hugo Obergeiser really gave us the tools for orthognathic surgery, if you will, sort of that lightning rod that Dr. Tessier did for craniofacial surgery. And he introduced those techniques at Walter Reed Army Hospital and really brought the revolution of facial skeletal surgery to Americans in 1966. And I think the issues of development of an intermediate splint followed by final splint really facilitated the ability to move two jaws in space, separated by individual osteotomy and then segment control followed by plating and then a sequential osteotomy. But really, I have to give credit to Praveen Patel, who's been pushing virtual surgical planning and really developed a lot of translational engineering technologies, particularly with CAD/CAM, computer-assisted design and computer-assisted manufacturing, and sort of bridging 3D photography as well as 3D printing, right? And all of these are technologies were designed to facilitate improved control of the facial skeletal osteotomies given to us either by Tessier or Huber-Geiser or then modified by others. So let's look at dento splint functions. Well, clearly they prevent rotation or tilting of the dentoalveolar segments and assist in fracture reduction. We want to prevent malocclusion by the establishment of centric occlusion. And most importantly, we want to provide long-term stability after our facial osteotomy movement and positioning. And so we want to reestablish pre-traumatic dental relationships or establish new predetermined occlusion, which is orthognathic surgery, and also prevent iatrogenic segmentation during fracture, for instance, during monoblock down fracture prior to facial bipartition. And what we've used always has been dental splints in some form or fashion. These are various illustrations of such. The more modern VSP or virtual surgical planning splints are here marked on my right, here in these two areas in the arrow. This is splint within a splint technology. So what are the steps in dental splint creation? Most people tuning into this webinar really realize that this is a labor-intensive process, really, with the taking of impressions, the pouring of the impressions, and fabricating of the dental models, the mounting of these models, followed by dental occlusion registry, and later cutting of the models, moving in the right position, and later fabricating acrylic splints to act as guides for facial skeletal segment motion, right? And so here's sort of what this process looks like. Most people are familiar with this labor-intensive process, and this is sort of segmentation using a Galletti, right? But I want you to notice that these require use of complex polymers. They require ordering, a logistics chain, and the ability to have a dental lab, which may or may not be easy to get access to in a plastic surgery department versus a dental department. So here's sort of what the type of cases we used to do pre-virtual surgical planning. Here's the results afterwards, double jaw surgery. And I don't think we had bad results by any means. But this is clearly a labor-intensive process. But what are the steps we can use now in a modern age? Well, I think the first thing is that we can either take a stone model and digitize it or go straight to a digital model. We use this at Hopkins, which is the 3M intraoral scanner. And I either take an impression and then digitally scan it or go straight to the patient and digitally scan their bite. This allows me to create a SQL file, which now gives me permanent record of the patient's teeth pre-intervention. I don't have to physically store the casts anymore. And this allows me a useful tool for research, a useful tool for the medical and dental record, and most importantly, a reproducible tool that I don't have to store. So I think this is definitely the future of digital occlusion, at least cataloging. We superimpose these digital images onto CT. We typically then use some form of commercially available CAD/CAM software, either through our various plating companies. And I think it's no surprise and no new knowledge that virtual surgical planning, in essence, requires no training. It requires no physical space. It requires, in essence, no equipment other than the occlusion bite registration and standing of the bite. The supplies are provided by the manufacturer, and in fact, there's minimal time required to the fabrication of the splint. And so, how do we do these? And I have to tell you, if you're going to do double jaw surgery, I've basically drilled it down to 8 simple and easy steps, right? You're going to plan some motion. You have a plan, whether it was digital or analog, And you already had a plan with how many millimeters you're going to move the maxilla and in what dimension. So really, the first maneuver is to move the maxilla or mandible, whichever one you want, to centric occlusion, okay? And then follow that by adjusting the maxillary midline, adjusting occlusal cant, and then lastly, adjusting the advancement of the maxillary position as well as its vertical position, right? And lastly, you're going to either rotate the occlusal plane counterclockwise or clockwise, right? That's occlusal plane correction. This is easily done digitally. I can tell you doing this on a stone model takes time. Anyone that's done this realizes this. And I would say to you, I think we're in an age now where you don't necessarily have to walk before you run, meaning I don't think you have to do stone modeling in order to truly know how to do digital planning. I think, this is along the same guidelines as AAA repair using endovascular treatment versus open, or doing a laparoscopic cholecystectomy. I don't think you have to do 10,000 open operations to have some sense of anatomy. I think the surgical body of advancement over the late 20th and 21st century has proven that this is not the case. Lastly, you're going to adjust the maxilla and mandible in basal view, which is really the yaw correction of the combined occlusion. And lastly, now your mandible is positioned passively. You don't have to do anything. And based on what you've done, it'll either tell you if the mandible moves forward or backward. So really, it's just a matter of determining how much vertical incisor show you want and where you want the mid-face position with the maxilla. And then lastly is adding a genioplasty, which is relatively straightforward. So let's look at some examples as we go through time. So I pulled Jim Zinn's article from some years ago, trying to understand, well, what's the actual cost to the surgeon? What's the actual cost to you if you're doing this particular procedure? And so here's looking at the actual time in preoperative preparation for doing double jaw surgery. And if you take a look at the 3 hours for a maxilla, 2 hours for a mandible, 5 hours of preparatory time for a double jaw. Look at the more common procedures done in plastic surgery, such as the tram, breast reduction, or lesion, clearly much shorter. And look at the reimbursement, right? Okay, so I think this is an interesting analysis, right? And so here was sort of this was Stephen Baker's original paper that looked at the average times, and this used actually a digital Facebook, which is no longer even necessary for virtual surgical planning, right? All you need is a CT scan with fine cut 1 millimeter cuts and a digitized occlusal bite from either direct occlusal scan or a stone model. And he averaged 26 minutes and 14 seconds for total prep time. So let's recalculate this data. And you know what you come to find actually is that it turns out tram is much more complex in terms of its preoperative planning. And if you look compared to, let's go back a couple slides, take a look for everyone. The actual reimbursement of doing orthognathic surgery is very similar to what I would argue any plastic surgery graduate can do now, which is tram surgery. So let's go back 2 slides and look at the discrepancy here. So I think, if anything, this does help you save time. But I think I've made a compelling argument that this means that your time is almost equal to doing breast surgery, which I would argue any plastic surgeon does and does often. So let's look at our armamentarium of facial skeletal osteotomies. Here's our typical armamentarium. And let's look at each variable example using virtual surgical planning. Dr. Gaby Doumit will look more at the cranial or cranial synostosis group, so I've chosen to do more frontofacial and occlusion surgery. So let's look at our first case example. This is, a patient with juvenile rheumatoid arthritis who has had completion of her anti-inflammatory treatment. Her bone scan shows no active disease in the condylar heads. And as you can tell, we have profound vertical maxillary access, occlusal cant abnormality, class 2 malocclusion with a significantly positive overjet, and microgenia and a very poor cervical mental definition, right? Her angle is basically obtuse and close to 170. So doing the same sequence of movements, right? We're going to first move the maxilla forward. We're then going to impact the maxilla. We're going to counterclockwise rotate the maxillary occlusal plane, correct yaw, correct the midlines. And once you set the maxilla in the place you want with the mandible in centric relation, it will tell you the final position of the mandible. You then add a genioplasty based on your own, right? This virtual surgical planning is by means a crutch for good surgical judgment. I think that's a critical point. But knowing what you want to do, just simply doing it digitally makes it much faster. And you can see these are huge motions. I mean, if you look at B point, we're moving 19 millimeters. If you look at Pogonion, we're moving 32 millimeters. This is by no means small motion. And doing this in stone is incredibly challenging, particularly with the intermediate splint and the large amount of material required to do that. In addition, you're going to have interference analysis. That's something you didn't have before with stone modeling, and as well as positioning of the infraalveolar nerve. I think that's helpful. I don't necessarily think we had a high infraalveolar nerve injury if you were doing your surgery well, but I think it's one more adjunct that can help. I don't know if it's cost effective, but it's certainly helpful to visualize. So let's look at our postoperative result, and I would argue that this is a very easy, reproducible thing that can be done with actually quite easy virtual surgical planning. Here's just a pre and post lateral view just to sort of highlight the translation and motion of the virtual surgical plan to reality. All right, let's look at this type of case. This is a case that I would argue would have been an incredibly labor-intensive phenomenon for anyone in the pre-virtual surgical world, right? This is a patient who has severe developmental delay. Has a typical class 2 division 1 occlusal pattern with both an occlusal cant abnormality, midline discrepancy, large overjet discrepancy, right? And this is a patient who would do very well with, I sort of coined the term, I like nathic surgery. This is surgery without braces first because you can't tolerate braces. And I think all of us would have different types of plans, but I thought this would be a good procedure for a Lefort 1 osteotomy, impaction, anterior apical osteotomy, premolar extraction, immediate setback, BSSO, and genioplasty. So this is going to require splint within a splint, right? Because we're going to have to take out the premolars and do an anterior apical osteotomy, including the Lefort 1, set into a final bite before we even go to the intermediate splint, have an intermediate splint dock within the final splint, right? And then do the osteotomy of the mandible, of the maxilla, dock and plate, followed by removal of the intermediate splint and then the mandible, right? This is 5 to 6 hours of work easily in the dental lab if you're doing splint within a splint, right? So let's look at the example of this. So here's the preoperative evaluation. You can see the numbers. Plan is the plan, whether you're doing it digitally or analog, with or without VSP. Your plan is not something you're doing virtually. The plan is something you bring to the virtual surgical session. So here's the plan. We're going to take out the number 5s, right? We're going to take out the first premolars on each side, and then the number 4s, and set back the anterior apical segment as well as level the occlusal plane and impact. Right. So here's what this operation looks like in execution. There's the Lefort 1 first cut. Arch bars are in place. Arch bars are then segmented. The anterior apical osteotomy is cut. It's critical to remove your premolar before you do the down fracture. It's just much simpler. It's just a technical note. And sort of here's what that looks like after you've removed the first premolar and set back the teeth and put into final splint with wires. You then dock with the splint within a splint and then plate, right? Once you're plated the maxilla, you then remove the intermediate splint, which is noted right here. You then cut the final mandible osteotomy and then go into final occlusion and plate. I happen to like intraoral drains for the mandible just to decrease postoperative edema. Not a whole lot of data, more training bias. But as you can see, this is a reasonable result, I think, for pure nathic surgery without orthodontic preparation and actually excellent control of the incisor plane inclination without orthodontics. So let's look at the class 2 example, occlusal cant, your typical hemifacial microsomia. This patient was at least mercifully spared and has an ear, but as you notice, look at porion here. This is something that would have been very challenging to set up with a classic face bow transfer, right? Because porion is different on both sides, which requires you to guess where you're going to put porion on one side. Whereas in a digital model and virtual surgical planning, you simply just choose a point north of where you're making your osteotomy and then drop perpendiculars, for instance, in this case, from glabella. So here's the motions that we planned. Here's the virtual surgical plan. As you can see, quite a pretty significant occlusal cant. Here's the intermediate position. Here's the final position with asymmetric genioplasty. There's the finite analysis of the advancement of the chin, right? And here's the plan. This is how many millimeters left I'm going to go as well as over. And this is, in essence, a propeller genioplasty, kind of standard type of thing for hemifacial. And here's our immediate result after surgery. I think, fairly reasonable, and most importantly, incredibly reproducible, particularly since you've taken out the Facebook transfer errors that I think I had a serious problem with during the first decade of orthognathic surgery in my practice. Another example of a class 2 patient, which, as you can tell here, look preoperatively, look at the variable positions of porion, right? And I think a very reasonable transfer of the digital plan in osteotomy. All right, let's go to the class 3 patient. So here's your typical patient with a class 3 cleft deformity. And yet again, the rules sort of stick the same. You're already going to come with your plan. I'm going to advance her, increase her incisor show, adjust the mandible occlusal plane, not more for advancement, for occlusal plane abnormality, and then lastly, genioplasty. Okay, so here's the sequence of events. Here's my plan. Here's it digitally executed. And here's the patient after Fort 1 BSSO and genioplasty. And I think this is a paper, we wrote some papers about cleft orthognathic surgery, and I think one of the critical points is that note that despite the alar cinch stitch, they increase alar width, and in order to control this, you're going to need a rhinoplasty. And so here's exactly what she looks like after a rhinoplasty and debanding, and I think a reasonable result using virtual surgical planning. Here's another example of a class 3 patient, pharyngeal flap, moderate VPI, sort of a typical situation, virtual surgical plan. After the Lefort BSSO genioplasty, pretty typical type of result. Again, note the alar base widening despite alar cinch stitch, the lack of genu correction, which is different than in non-cleft orthognathic nasal change. We wrote a paper in JCS looking at this issue. And here she is after rhinoplasty, right? You can see a pretty reasonable occlusal result. So what about distraction? I have to tell you, I've done a fair number of virtual surgical planning using distraction. I would argue the benefit here is marginal at best. This is sort of what happens typically after you advance. You may have an open bite deformity, and when you take out the internal distraction device, you're going to re-hit the osteotomy, dock into perfect occlusion, and then plate. So I'm not entirely certain if VSP perhaps really gives you, what you need, after Lefort and then after rhinoplasty. But I think it's a technology and evolution, particularly here. Here's another example of a Lefort 1 distraction patient. I think reasonable result, but I'm not sure that it gave me as much technical advance as I would need, for instance, in a one-jaw, one-step case or two-jaw, one-step case. So let's look at sort of an interesting example of trying to make VSP better. I have to tell you, so orbital surgery, for instance, I think is an area that can really benefit. I think anyone who's taken on these types of cases, which is neurofibromatosis, particularly in the ocular area, can be challenging. So here's your typical patient with, after debulking of the neurofibroma, who's left with enophthalmos, cyclotropia, esotropia, and enophthalmos. And what makes this patient, I think, particularly challenging is, if you will, the mild exorbitism on the normal non-disease side, right? And anyone that's done this knows that this can be a challenging thing to determine how much the orbit you're going to raise, how much you're going to compress, where you're going to deal with the orbital floor. So here's sort of where a virtual surgical planning, I think, can really help in this type of challenging situation. So we know this orbital volume is expanded. We know the supraorbital bar is too high. We know the orbital rim is in the wrong position. And we also know that the total orbital volume is expanded. Okay, so we're going to plan on doing an orbital osteotomy. We're going to raise the medial canthus. Let's look preoperatively here. You can tell here, looking at this picture, that the patient's medial canthus would benefit being moved up here. So we're going to do an orbital box osteotomy first, lift the entire box up, plate the NM and ZM buttresses, NM, ZM buttress, then segment the FOA segment, remove the intervening bone segment, compress the orbit, repair the cranial defect, and then also use custom orbital implants. And I'll show you how you can use a custom orbital implant to improve both the external shape of the orbit and then match, more importantly, the internal shape. This is where I think you have a lot of challenge trying to put split bone grafts in the orbit and achieving normal volume. So here's sort of what this looks like. You can tell the shape of the orbits are better. And this is the actual plan. It will tell you, using virtual surgical mirroring, right? You take the normal orbit here and use the mirror function here. And then you can tell exactly how much the upper aspect of the FOA needs to come down as well as the orbit coming up. Right? Cutting guides can be helpful. I find these marginal. I'm pretty good at dead reckoning these, but they can be helpful. Here's sort of what this looks like on the enophthalmic or intraorbital side. And this is a really interesting thing. So you can mirror the contralateral normal orbit and then have a custom patient-specific implant to reproduce the exact orbital volume on the disease site, right? So the orbital box and compression is going to control the external orbit, and you're going to use an internal implant to control the internal orbit. Here's what this sort of looks like with the box osteotomy virtually executed with a custom implant. Here's what this looks like in reality, right? So osteotomy marked here. This is the distance we're going to come up from there to there, right? The osteotomy is elevated. We're plated in the mouth. The FOA segment is then now cut free, as noted here, right? And then you're going to take out this much bone to compress. You're going to reproduce all this. Before you put all this back together again, of course, you're going to place your custom orbital implant, as noted. And here's your results, which I think are very reasonable in terms of matching enophthalmos to correction to, I would say, a reasonable correction, particularly in the worm's eye. So let's look at, lastly, facial segmentation. Here's an example of the facial bipartition. I think getting a custom splint made for this during down fracture can be very helpful. I don't find this VSP particularly helpful for bipartition procedure, but I do find predicting and designing the V-shaped wedge excision does take off some time by having this pre-drawn as a cutting guide. I think that's actually quite helpful than taking time with the calipers over to measure the intradactylian distance. And obviously, the palatal splint is much faster to make virtual surgical than you doing it in your lab for the down fracture and to avoid iatrogenic splitting. So let's look at this case. Here's a case of a Pfeiffer patient, previous failed of 4-3, cantilever bone graft that's been moved to the patient's left side, and the class 3 malocclusion, right? Cyclotropia and esotropia. So here's the virtual surgical plan preoperatively. Here's it with the bipartition. Here it is with the advancement with an internal distraction system. Here it is advanced. Here's the patient in operation. Pericranial flap, internal distractors, and using that pre-surgical guide for the central bipartition, like I said, it makes it a quick and easy mark and cut. And here's sort of what they look like, what the kid looks like afterwards with the correction of the occlusal cant and the occlusion. As you can see here, he's now ready for his ptosis repair and his strabismus correction. So I would say to you, in conclusion, that the dental lab in the future may certainly not be necessary to perform quality orthognathic surgery or facial skeletal surgery. And whether we like it or not, this has always been a very crippling aspect in most plastic surgical programs without access to the dental lab. I would say stone models are only required if the dental lab product is needed for VSP. Otherwise, you can go with a total digital scan. I think the overall quality may be maintained without a dental lab, and certain future research will determine if national trends in orthognathic surgery and orbital surgery, which have decreased over the years, particularly if you quote Jim Zinn's paper, to see if these are stabilized or reversed. I certainly hope they are for the future of our specialty. Of course, I'd like to thank, we have a large team at Hopkins, and this is a team sport, as everyone knows who's online here. So I'd just like to thank each one of them. Thank you. Any questions?
Thank you very much.
Type in.
Thank you, Dr. Kumar. We do have 2 questions from Dr. Gosain that have come in.
Okay. I don't see them yet. I'm looking.
Okay. The first question was, could you define the term yaw?
Yes. So yaw is going to be, there's 3 planes of motion, typically similar to an airplane. There's going to be pitch, yaw, and roll. So roll is the side-to-side motion of the maxilla, which is typically used to correct an occlusal cant. The pitch is typically the up and down of the incisors, right? That's what you're going to use to control your occlusal plane abnormality. And your yaw, it's the side-to-side motion of the jaw, almost rotary in space, that controls the midline. Right, so each one of those 3 motions, pitch, yaw, and roll, just like a plane, is going to give you ultimate control of your maxilla or mandible.
And Dr. Kumar, can you see the second question?
No, I don't, unfortunately. I'm sorry. I
Okay.
apologize.
No, that's okay. No problem. I will read it to you. This is also from Dr. Kosane. Could you provide your preference for which jaw to fix first when performing two-jaw surgery so as to
Sure.
minimize the chance for
Yeah,
occlusal
so
mismatch once the patient awakes and the fixation is removed?
Yeah, so this is a great question. Okay, so in the age pre-VSP, if I had a patient with a huge occlusal plane abnormality, particularly an abnormality of roll, right? This is a patient with an occlusal cant. The intermediate splint was typically quite horrendous, right? And the amount of orthodontic resin you had to use to build up the one side, right, where you have now created an iatrogenic open bite was immense, right? So actually fabricating the splint made it very difficult. So this was a classic indication for doing a mandible first procedure, right? Or if you were going to segment the maxilla into three pieces and you're going to do a splint within a splint and you just didn't have the fortitude to take the beating of doing a splint within a splint in a dental lab, you would have done the mandible first and then gone to a final one-piece maxillary splint. So I think with virtual surgical planning, I personally like to go with the maxilla for one reason. I like to set incisor show, pitch, angle, and control the forward advancement of the midface prior to the mandible osteotomy. I think anyone that does a fair amount of orthognathic surgery is not going to have issues controlling centric relation. So I go with the maxilla first, and using VSP, I don't have to worry about these issues of building up the acrylic for the intermediate splint, which was horrendous, and I can go a splint within a splint. So I don't mind doing a multi-piece Lafort, going straight to the final splint, wiring that in, and then using a splint within a splint technology to then do the mandible surgery. So I think using VSP, I think it doesn't matter as much as it once did due to those two very, I think, legitimate technical points that really affected you in the dental lab. I mean, doing a splint within a splint honestly can take hours if you actually take pride in what you do and polishing and making sure everything is perfect. It's very challenging.
And we have a question from Dr. Pape. What is the average cost per case in the role of insurance coverage?
Sure. So this is a really interesting case, and I would say to you, I'm a capitalist. There's no question, and so I can tell you at Hopkins, it's very interesting. We have actually seen no change in the cost of doing virtual surgical planning because what's happened is each company compete. Hopkins is a very competitive market for using hardware. And what's happened is each company, we now have a single unified price for combined VSP plus hardware for each orthognathic case. So it's not a la carte, it's now bundled. And so each company, Stryker, Synthes, and KLS Martin, which are our three biggest companies, each in essence are in a bidding war now to drop the cost. So the average cost for us to do this entire procedure hardware-wise is $3,500, which includes VSP plus typically 4 maxillary plates and 2 mandible plates. So that's the hardware cost is about $3,500. Just to put that in perspective, the average cost of one pedicle screw for spine surgery is $2,000 per pedicle screw. I hope that helps
Does
answer the question.
Do any of the other attendees have questions at this time for Dr. Kumar? We have an additional question coming in. It says, with complex osteotomy planning, impaction, down fracture, correction of yaw, roll, pitch, do you need special cutting guides or splints with attachments? In other words, how do you make sure that your VSP plan actually translates?
Sure. So that's a great question. So really, your yaw, roll, and pitch are going to be corrected by your splint, right? The splint is going to dock you. The thickness of the splint on one side or the other is what's really correcting the yaw, the pitch, and the roll. So the only and also the incisor inclination, right? So obviously, if you do your virtual surgical plan where you're planning on a counterclockwise rotation, you're going to have a greater amount of acrylic in the front of your splint compared to the back of your splint. If you're going to do a clockwise rotation, you may have a greater amount of acrylic in the posterior aspect of your splint than in the front, right? To obviously decrease or I'm sorry, increase the amount of incisor show, right? So once you place the patient into centric occlusion with whatever wires or elastics, your next move now, as you seat the patient into centric relation with the condyles in, is now you're just simply rotating the whole complex back up to determine the incisor show. So I think I like that part of the operation because the VSP is in essence now controlled your midlines, it's controlled your yaw, and it's controlled your roll. But the one thing you still have some flexibility in is how much incisor show you want. Because I think each person's a little different and the amount of scar tissue, particularly with a cleft case, may not be as easy to predict, right? So that's where the splint's going to correct all of those dental issues that you need. And now you're going to set the incisor show based on the impaction or down motion of the complex of the jaw on the condyles. So I think you do that, it gives you, I think, the best of both worlds, right? It allows you to control in real time incisor show, which I think is very important, but also correct those other issues which you don't want to rely on your judgment, I think, such as pitch, yaw, and roll. So I think that's how you can control that.
We have another question about time saving with pre-bent plates.
Sure. So I think there's no question that pre-bent plates can be quite helpful. I would argue that whether you pre-bend your, I think if you're fast at what you do and you do a lot of jaw surgery, you can pre-bend a plate in under 15 seconds. So I don't think the timing issue is as critical as this particular issue, which is you want your plate at 1.5 millimeters of thickness or less, right? Because the one thing you don't have, as soon as you hit 2.0 and 2.3 in the maxilla, you don't have a lot of room to make up for any errors postoperatively, meaning semi-rigid fixation of the maxilla with a 1.5 millimeter plate allows you to use a 6-ounce elastic after surgery to guide the bite, right? So let's say you're slightly off. You have asymmetric swelling on one side or the other after jaw surgery, right? The patient happens to sleep on the right side. You can adjust your elastic, right? You can use a cross elastic, a class 3 elastic, a class 2. I personally like class 2 elastics in class 2 patients and class 3 elastics in class 3 patients to reinforce the motion of the skeleton that I've done. But more importantly, it allows you to adjust micromotion of your bite. You start using 2.0, 2.3, and 2.5 plates in the maxilla, you have rigid fixation. I have zero room for correction using elastic. So I would argue a little bit of fudge or semi-rigid fixation is a better thing.
We had an additional question with complex cystotomy. Oh, we had entered that, excuse me. Who usually pays or VSP? Does insurance over it, or is it billed to the insurance company?
Yeah, so at least I can tell you, so two things. Everybody's medical economic system, it's a microcosm in and of itself, and it's different in every place you go. So in Hopkins, the insurance is billed, the billing of the hardware is billed to the insurance, the medical insurance. And so the hospital is very interested in making sure that you have a bundled package for that particular operation. So for me, I like it. I'm in a training hospital, so the hospital has contracted with the manufacturer that the cost, for instance, is $3,500 for that maxillofacial double jaw procedure, typically $4,500 for double jaw plus genioplasty. Because if you will, I burn through multiple plates with my trainees learning how to bend plates, and I'm not penalized for that. So I think it depends on where you're at, if you're with or without residents or not, right? So it's like when I was in the military, if you're in a training command, you have to accept error. And if you're training, you're not going to get efficiency. Efficiency comes with competency in executing something multiple times, right? So I think this is an area that's imperative that if you're in the training area, that you try to get bundled package software or bundled package hardware for the cases you're doing, and it allows you the flexibility of training. Otherwise, you're in a situation where you can't allow people to train, and you have to be tolerant of error. If there's one thing I've learned over the last 5 to 10 years to try to be a better teacher is to learn how to tolerate error. So I hope that helps answering that question.
And we have 2 additional questions. If you don't see them yet, I can read them.
Yep, please do. I can't see them. I'm sorry.
Okay, that is fine. No problem. The next question, do you need to outsource the VSP modeling and printing, or can a surgeon do it by him or herself? Also, with the intraoral scanner, do you still need to send the company a dental cast showing the final occlusion?
Yes, so those are great questions. So the answer to the second question is unfortunately, at this point, you still need to send the casts with the final occlusion because if you use Dolphin, which I use in my clinic as my orthodontic record keeping software, really 3M or 3D Systems is using Dolphin or proprietary version of Dolphin to do that. And it's hard for them to find, because they don't have haptic feedback with the models to figure out exactly where the perfect bite is. So they do require that. So currently, I still obtain stone models, even though I scan them for my own record so I don't have to keep them later. But you do still need stone models at this time. And then the first question, I believe, was, can you repeat that one more time, Stan?
Yeah, just absolutely. Do you need to outsource the VSP modeling and printing, or can a surgeon do it by him or herself?
Oh, okay, so this is just a class. This is a medical legal question, not a technological question. Because the answer is, if you have Dolphin, you have the digital modeling software sitting in your computer. And if you have a 3D printer, you can simply print your thing. So the question is, do you have a certified process, like anything, that you're going to take, put into a patient, and recognize that it's going to be reproducible, certifiable, and safe, right? So these are the real issues, right? I think this is the difference between putting something together and also interfacing with something in a system, right? So I would argue that the answer is not technically, can you do it in your dentofacial lab? The answer is, if you're going to do something now, using virtual surgical planning and a 3D printing, do you have some quality control or measure that you know that what you've printed on your computer, or what's on your computer, is being printed properly, right? And I would argue, I don't know. I'm not in the business of that. So, and if you're looking at economy of scale, I would say it would be better to go to a place and send your thing to Kinko's and have it printed, by someone who's doing it all the time, so you don't have to manufacture or maintain your equipment. So I think it's neat to print your own stuff. I'm not sure it's economical.
And our final question, using VSP, do you see any difference in post-op relapse? What is your relapse rate and percent in cleft and CF orthognathic?
Okay, so that's a great question. So this is just like lap chole, which is, the operation hasn't changed, just how we do the operation. The human being and the factors that came before have not changed. And I don't know anyone that's reported that they've had a decrease in relapse rate in the cleft orthognathic patient using VSP versus non-VSP. I don't have that data particularly, but I would surmise that there is no difference because VSP has not changed the basic problem of biology. One of the first papers I wrote with Jim Bradley and Henry Kawamoto years ago was looking at the comparison of Lefort 1 distraction versus Lefort 1-step advancement. And there's a linear relationship with, the greater the advancement, with a higher rate of VPI and a higher rate of relapse. And I would argue there's absolutely no difference in that, I think, with VSP or analog fabrication. Although I'd love to do the study. I think that's a great question. Feel free to email me offline. Love to collaborate, whoever sent that.
Very good.
Awesome. Thanks,
Okay,
Dan.
thank you.
Yeah, thanks
And
for everyone who signed up. It's just awesome and so great to be able to present to you. So thank you.
okay, and we will proceed with Dr. Doumit's presentation. Dr. Doumit, do you see your presentation on the screen?
No, I see Dr. Kumar presentation.
Okay, I'm pulling it up from a separate pod at this time, and you should see it now.
Yeah, thank you, Stan. Thank you for the invitation. Thank you for having me. Thanks for everyone for signing up. We'll be talking tonight about virtual surgical planning in craniofacial surgery. Dr. Kumar did a great job covering the history and the orthognathic part of the talk. And the goal today is to focus more on the craniofacial part. And I want to jump in more into a clinical situation where I felt that advanced virtual surgical planning will be helpful in achieving better results or making surgery more reproducible and safer and easier. So, um, obviously, CAD/CAM technology for complex craniofacial surgery, I believe it's a gold standard. It gives you a roadmap for your surgery, and you could plan it ahead of time, and you come to the surgery, you're fully prepared, and you have the roadmap in front of you. It's almost like your GPS. So CAD/CAM stands for computer-aided design, and CAM comes for computer-aided modeling with virtual surgery. Obviously, the basic of all things is to basically have your diagnosis. What's the deformity? What's the malformation here? You need to cut CT scan. For orthodontic surgery, as Dr. Kumar mentioned, you need the stone model or laser scan, and you do your CAD/CAM workup, which Dr. Kumar went extensively in. I believe, especially in terms of orthodontic and facial asymmetry, hemifacial microsomia, it is extremely helpful. And I'll show you a couple of cases where it does make a big difference versus stone model. So this first case, he's a 6-year-old boy that presented with unoperated sagittal synostosis. And this is his frontal and profile pictures. And the mother already saw a colleague of mine and told him it's a bit too late to do much surgery, and with skull base is too long, that it's not going to be a big difference. So the mom came for a second opinion, and she asked me, could you do something about it? And the answer was yes. And she said, could you show me what the result could be? So the plan was to do the virtual surgical planning to use as a kind of possibly post-operative outcome that the mom could see if it's worth it for her son to go to undergo surgery, especially other surgeons told her that it's not going to make another difference. Now, where I currently practice is in Canada, and the economy when I planned that surgery was if you need to have the guides for the surgery, the cost would be about $7,000 versus if you do the pre and post-op planning, it's about $750. So I decided not to have the guide printed, but at least you plan the surgery virtually and you will have the post-op results. So this is a CT scan. You could see he's quietly scapulocephalic. This is the plans and the osteotomy I was planning virtually and repositioning. And this is a superimposition of before and after that I did very conservatively for the mother, that at least she won't be deceived with the result post-operatively. Now this is intra-op after exposing the entire cranium and the osteotomy marked. This is after removing basically doing a total cranial vault remodeling, removing the entire cranium and placing it back in a normal total cranial vault remodeling surgery. And he's 6 years old, so we had to fill all the gaps. And this is his post-op results, which the mother was quite satisfied. And as I said, when I planned it, I planned it very conservatively, and she still wanted to go ahead with the surgery. So in this case, the virtual surgical planning, in some way, we used it to discuss the case with the parents. Second, we used it to go over the osteotomies and accelerate the surgery. And third, if you could print the splints actually and use them as a cutting guide, and will make your surgery easier, but because of budget concern, went ahead and just did it freehand. This is other profile pictures. And his x-rays pre and post. So this is another gentleman that he came, he's a 52-year-old, he's CEO of a hospital in Pennsylvania, and he had hemifacial microsomia. He underwent previously bimaxillary surgery 20 years ago, or more than 20 years ago, actually, by Dr. McCarthy. And he had a left scapular flap, free flap, by Dr. Shaw at NYU. And then over the years, he felt that his shin was quite asymmetric, deviated to the left side, and his free flap in his left cheek kept descending, despite being resuspended a couple of times by Dr. Shaw using tendon resuspension. He has other two surgeons that do the same things, and after a few months, the free flap basically become more ptotic and descend. So at that point, if you look at this is a smile view, profile pictures. So, and his occlusion actually is in class 1 occlusion. So his bite has maintained over the 20, 30 years span. So we obtained a CT scan, and when you look at the CT scan, actually, he had a quite severe facial asymmetry on the skeletal. I mean, you look at the width of the mandible on the left side, you can see his, obviously, it's completely off. The width, you can see as well that the chin is deviated to the left side. We see where the osteotomy and the recurrence. So, and the basis of facial symmetry is skeletal symmetry, I believe, before you do anything with the soft tissue. So in that point, the plan was we planned his surgery by, I said, if surgery has failed previously by resuspending the flap 4 times by excellent surgeon, if plan A has failed, I'm not going to repeat plan A. I have to go to plan B. And at that point, I decided to excise actually the free flap and do fat grafting, improve his skeletal symmetry with a mandibular angle implant on the left side. I believe it's for that purpose, it's more accurate than a bone graft. You can shape it better and it will not resorb over time. And to do a genioplasty, and all of that was planned virtually. So I'll take you over that case. You can see the mandible asymmetry between the left and right. I just want to, this is a mirror image. And from the mirror image, I had a meeting with the engineer to form a MedPor or porous polyethylene implant to place on the left mandible angle. Now, if you could see, if you want to form a completely mirror image, that implant actually is going to be just pushing on the mucosa. It's going to go up to the coronoid and the condyle. So anatomically, it's not feasible. So you have to use your surgical and anatomical knowledge to adjust what's feasible anatomically and what's actually safe for long-term implant placement. So this is the implant. After removing some part of it, that it will jeopardize the surgery, the safety of the surgery. And this is the implant on profile view. Now I had a video which for some reason on the webinar is not working, so I'm going to skip it, how I engineered it with the engineer, how we worked it out. And this is the implant during surgery, and they send you a 3D printing of the mandible and how it sits. And actually, it would sit just perfectly to the mandible. This is during surgery. You can see actually his chin after doing the intraoral incision. This is the implant that will guide placement of, you don't really need it, but we obtain it to guide, it's an interdental splint that will guide the genioplasty. And that's him post-operatively with his symmetry improved significantly. And he's actually quite happy with the results. This is another child that have a type 1 neurofibromatosis. She's 14-year-old, and actually she has seen many surgeons, and throughout the years, the craniofacial surgeon told her there's not much we could do for you. And I have actually record for her yearly record, and her deformity worsening and worsening. And remember the first time she came to the office, actually, that she was hiding half of her face with her hair. So you can see the severe neurofibromatosis involving soft tissue. She has actually severe vertical dystopia. Her left lobe is about 2 centimeters inferiorly displaced. And actually, she had literally no vision on the left side. This is her left profile pictures of her neurofibromatosis. This is actually, you can see the CT scan. This is the CT scan showing, you can see actually the dura and the brain. You can see the globe, how it's in an exophthalmic, severely exophthalmic position. You can see over here her orbital floor. It's about 2 centimeters inferiorly displaced and remodeled because of the brain herniation and absence of sphenoid ring, great sphenoid ring. This is her 3D CT scan. And at that point, the neurosurgeon were actually reluctant to operate on her. They were worried about, having swelling and edema post-operatively, etc. And especially it was in the same hospital that she got refused to be operated on for many, many years. And now we're telling the family different that something could be done. And actually, you can see as well her temporal bone laterally displaced and everything enlarged. So I decided in this case actually to plan it virtually, and almost the same case as Anand. Maybe this is, I believe, is more severe deformity. So I planned and I told them to give me a mirror image of the normal side, but I felt normal image of the normal side by itself is not going to be very helpful. So I have them superimpose actually the normal image on the abnormal image, and as well with the cost effectiveness in mind, I had them print a model with the mirror image superimposing on the actual deformity, and I used the actual deformity to bend my plate preoperatively and give me a guide where exactly her orbit has to be. And I took a mesh, 1mm mesh, pre-bended on the model. I made a one for the orbital floor, one for the roof, and one laterally to guide me exactly, to give me the space for the orbit. The neurosurgeon did not want to touch. We didn't want to bring the temporal, so he decided it would be too much edema, and he didn't want to compromise. So I basically literally were working on the zygoma and the orbit, and did all the dissection where we dissected the preorbita from the dura, and I reduced it back while they were watching. So this is her actually post-operatively. Obviously, she still need further resection of her soft tissue, and the other thing is that despite her blindness, the ophthalmologist did not want to do enucleation at the time of her surgery. He wanted to see what type of construction I would be able to do, and then from that judge if he need to do the enucleation or not, and it was done at a later stage. And this is her CT reconstruction and 3D. This is another kid that I had the pleasure to operate on with Dr. Frank Pape from Cleveland Clinic. She's a 14-year-old with fibrous dysplasia that's been going on for many, many years. So I'm just, moving through different cases where I feel virtual surgical planning is essential for those severe, tumors, the large tumors, the asymmetry and severe cases, craniofacial cases. And actually, this patient had 9 previous resection, and in big centers in the state, from California to Kentucky to other places. And after every resection, the tumor will come back, and it will come back more aggressively. Her father is a veteran, and he came to the Cleveland Clinic to discuss face transplant. So this is her profile pictures. And you can see actually the fibrous dysplasia goes up to the cribriform plate, all the way back to the nasopharynx. It replaced all the the heart palate, caused severe hypertelorism, and replaced most of your orbital walls. And this is her 3D. Obviously, there is no mid-face landmark. So the surgical planning in her case, that was this case done about 3 years ago, and the plan is that this tumor recurred, after 2-3 months, despite resection by excellent craniofacial and head and neck surgeon across the country. And at that point, my plan was not to burn any flap bridge or any free flap or bone perhaps, and to temporize her with titanium mesh reconstruction to maintain her soft tissue envelope. So my discussion with the engineer was to print me within her age group and race a actually mid face that will go with her bizygomatic widths and her maxilla alveolus. So that's what we did, and they sent us 3D printing of her skulls with a tumor, which I felt it was useless. But what's the most helpful was with the reconstruction, actually having a 3D model with normal anatomy for her age group and sex and her anatomy. And this is preoperatively pre-bend a titanium mesh on her facial skeleton. And actually, the only thing I would tell you is that during surgery, because they sent me a normal interdicron distance. So, and actually, in fact, she had a severe hypertelorism, so I had to readjust that during surgery. So this is actually, before we got to her, it was about 6-8 weeks waiting time, and you could see that compared to preoperatively that her tumor has enlarged in a significant fashion. And doing a Weber-Ferguson incision, debulking most of the tumor. Initially, that's actually after taking about 10 centimeters from the anterior projection. And then able to find actually a very nice plane between the fibrous dysplasia and her zygomatic, which I was able to follow and dissect completely the tumor off the cribriform plate. There was no orbital floor, no medial walls. They all were basically replaced or got atrophied and resorbed because of the tumor expansion. And the malleable actually here are on the periorbita all the way back to the orbital apex. So this is after removing the entire tumor. The only thing that was, all the buttresses were gone, the medial and lateral buttresses. I left the alveolus, and I felt that the tumor started from around the pterygomaxillary fissure on the right side. And I felt maybe the deformity, if I do a complete maxillectomy on her, taking the alveolus, will be way severe. That I said, maybe I should leave it and watch and see what's going to happen. So, and this is her actually after 3 years without any recurrence. And she's still doing very well with no titanium extrusion. And we have done multiple endoscopy, and actually it's all mucosolized. So this is her profile pictures, and this is her nostrils. And this is her pre-op CT scan. As you can see, everything been reconstructed, orbit, mid-face, all of that with a titanium mesh. And this is her orbit. This is another case, girl that have a right unilateral condylar hyperplasia, orbit. She had a severe occlusal can about 5 millimeter, and she had a severe facial asymmetry, and she is depressed, living in that condition. So you can see her severe occlusal cant, and her right jawline is much severely inferiorly displaced. And you can see her occlusal cant in this picture. CT scan. This is a PET CT with showing the uptake of her right condylar hyperplasia. So the plan was to do a Lefort-1 BSSO genoplasty. And by doing the medical modeling, actually, while doing the plan, even after correcting for the occlusal cant, we realized actually that she will still have facial asymmetry on the right side because of her condylar hypoplasia and the length, the height of the ramus. So at that point, despite correcting for occlusal cant, we felt that it's best to do as well an inferior right mandible osteotomy to further improve her facial symmetry. And by doing virtual surgical planning, we were able to get a actually guide, and you can see that guide. This is the mental nerve that we place on the inferior border of the mandible in order to basically safely resect the inferior border of the mandible, further improve facial symmetry without compromising the mental nerve, because we could see on the CT scan where the mental nerve was. And by doing this is a piece of bone that we took from the inferior border of the mandible. This is a couple weeks after her surgery. And this is actually her results 6 months after her BSSO, Lefort 1, and genioplasty and inferior mandible osteotectomy. This is actually a distraction case I did with Dr. Pape. He's a 7-year-old male with golden heart syndrome, and we use virtual surgical planning. You can see he has a type 2 K-band classification, and so we planned his distraction vectors. And actually, his parents were, could not come to the clinic quite regularly because of their schedule. So by doing the planning and where we wanted the jaw to be, I was able to tell them on the right we have to move it inferiorly 25, on the left inferiorly 15. So you're gonna rotate so much for so many days, and then we're gonna move them anteriorly this in order to obtain the occlusal plane, and the position of the mandible that we wanted. So in this case, actually, we used it to guide the post-operative planning of the distractor, how much we need to turn it, and there was no guesswork, and it basically gave us exactly how much we need to turn in order to obtain the occlusal plane that we want and the position of the mandible that we wanted. And this is him at the end of surgery. At that point, I left after the Cleveland Clinic, and I don't have his present result. As well, you could use virtual surgical planning in face transplant. This is a gentleman that had Wigner, and he had severe facial trauma, that had pleasure to do his participate in his facial transplant at the Cleveland Clinic. We obtained 3D model. We planned the osteotomies and surgery. Thank you. And
Thank you, Dr. Doumit, very much. My speaker's back on now, and I've also been looking to see if we had any questions come in. I do not yet see any. The attendees can please take this time to ask Dr. Doumit questions. I show that we still have about 15 attendees. Please feel free to take this time to ask. Yes, we have one question coming in. How do you choose a virtual planning software? Are there any major differences between 3DMD, Dolphin, and other products?
So I have Dolphin actually, and I have 3D Dolphin, and medical modeling, which is 3D system now, that's what they use. They use Dolphin. And I used to play and do the orthognathic 3D planning myself. And actually, you could do it yourself and do all the osteotomies and all the advancement, and then have a file. And if you have a 3D printer in your hospital, you could actually print that file, because all what the engineer are doing are preparing the file for you. And there's two elements that will make your life easy. If you have that digital scanner, that will make your life easier, because otherwise, if you do obtain a CT scan and you have the brackets on and you're trying to clean the teeth to have a good occlusion and print that for the splint, is much more difficult, and it will take you about an hour actually to prepare that file by doing the osteotomy and getting the orientation well, and etc. So it used to take me about an hour and a half to do all the Dolphin planning and do the cephalometrics and get everything done. Or you could go directly to them, to 3D medical modeling or any company, If you only, I know Anand mentioned they pay about 3,500. If you only order the splint and the planning with them, the cost is $950 per case. And that actually, you never see that bill, because that bill, what they do is you order through one of the plating companies, and the plating companies will bill it as part of the hardware. So if you use plating things for $1,000, then you're gonna get billed. The hospital gonna get the bill for 1950, and they don't even know that 950 was actually for the splint and for the virtual surgical plan.
Was the implant for mandibular augmentation that you showed under some sort of FDA regulation?
Well, I mean, that implant actually is made of course polyethylene, which is, people know it as Metfor. It was the separate company, and it was bought by Stryker. I know Synthes have their own line. I think it's called maybe Synfor. There was another companies from Georgia. They came up with their own product. Those are very actually common products, and you could use them for chin implants, for mandible angle implants, for cheek implants. Polyethylene is very widely used. Actually, they're much more superior than silicone, I believe, because they're porous. You're going to have tissue integration into them, and usually that implant you fix to the bone with a couple of screws. It will never move, never cause any bone resorption. So it's a superior product, I believe, than silicone. They're more expensive, probably double the cost of silicone implants, and the cost of that implant in planning is about $7,000 to $8,000 for the custom made implant.
Next question, is the Canadian medical system different in price acceptance of VSP?
No, I mean the price is the same, but here in Canada, you don't have insurance billing, so the hospital get a yearly stipend from the government, and that's basically their budget for the entire year. So they put a lot of pressure on you to limit your OR time, or limit how much money you're gonna spend. So in reality, it makes your surgery a bit more. You have to be more cost effective where you want to use your money, because the money is not endless. I mean, when I was practicing at the Cleveland Clinic, you could order wherever you want, and I mean, it's good and bad, because you could then order more than you want, and it will increase the cost of healthcare, and then things changing as they're happening now in the state. But so here, if you need it, you order it. If you don't need it, then you probably should not order it, and you could just get the plan. You could just do the planning, and if you feel the splint's not going to help you much, I'm not going to spend $7,000 for just having a splint and not use it in the operating room. So that's why you think twice before you do a move.
How do you choose a virtual planning software? Are there major differences between 3DMD, Dolphin, and other products?
Dolphin is mainly for cephalometrics and orthodontic surgery. They have other software that they do. I think CAD/CAM software that they use for the other craniofacial surgery. It's not Dolphin. Dolphin is only good mostly for it's built actually for orthodontists and orthodontic surgery. It's not craniofacial software. So when you deal with those companies, they have other software for the other products, for the other surgeries.
Ultimately, does the patient have to pay for VSP, or is it billed to the insurance company as part of the plating fee?
No, the patient does not. Well, the patient, I could tell you, the patient will pay for VSP if it's a private case. So if somebody comes to you for an aesthetic, facial asymmetry, and they want to pay it, then they will pay for the VSP and the implant. Otherwise, if you're doing it not in a private setting, then it's going to be billed under the hardware, and directly to under the plating company.
As you plan the bone movement, do you see immediate feedback on soft tissue changes, and is it accurate?
Correct. You could, I didn't show the picture, but you could superimpose, whether for orthodontic surgery or craniofacial surgery, you superimpose a soft tissue envelope on your skeletal movement. You know, I do that regularly. Now, the accuracy of this, just subjectively, without doing any data on it, actually, it's quite accurate.
I believe the word is indications. The question is, how has your indications for VSP changed? What are the case types?
I reserve VSP, you know, for regular, for example, regular cranial bulk case, metopic or coronal or bicoronal. I don't find it's not going to change anything for me. Even when I was planning this, you know, severe scapulocephaly, actually my osteotomies intraop, which is more difficult to do on computer, were not the same. I was doing a finger type, you know, osteotomy in the parietal bone to overlap them, and on the computer, the idea was, you know, I didn't want to waste time and do that. Just make it, add it as a box. But I believe where I find that virtual surgical planning is crucial is when I do those severe, you know, bimaxillary surgery, when you have a facial asymmetry. If you're doing 2-jaw surgery, you don't want to go to the lab, it's not worth it. Cost $900, you get your splint, and you get way more accurate. If you're doing a facial asymmetry or an orbit case, and I think having a 3D printed model or a mirror image with overlap, you can bend those plates preoperatively. You know what to expect, and you sterilize them, and you save you a lot of cost in the operating room. So for the facial asymmetry, I think actually it's quite helpful.
And in scrolling through the questions we've received, I believe this is the last one. Was the implant for mandibular augmentation that you showed under some sort of FDA regulation?
I mean, all of this is, the porous polyethylene actually has been FDA approved for a very long time. It's been used in the state for a very long time. So it's approved.
Thank you, Dr. Doumit. Are there any more questions for Dr. Doumit this evening? Hearing or seeing none, we thank you all for attending this evening's webinar. Thank you for Dr. Doumit and Dr. Kumar's time this evening and presenting it to you. We encourage you to visit the ASMS website regularly for more announcements about the potential of future webinars and other programs. Thank you all again for your attendance this evening.
Thank you all for participating. It has been a pleasure, and hopefully we'll see you at future ASMS events.
And this concludes this evening's webinar. Thank you so much to all. Have a good evening.